Go up. Oh, movie then.
Good evening. Am I audible?
Yes, sir, you are absolutely loud and clear.
Okay. I welcome all my dear friends. At the outset, let me thank the organizers for inviting me to give a talk on secondary diabetes, when to suspect. And if you look at the topic, the secondary forms of diabetes include those diabetes or glucose intolerance that develops in association with other disorders or factors. The prevalence is around 1 to 2% of all diabetes. The extent of glucose intolerance in patients with secondary forms of diabetes can vary widely, presenting as overt diabetes, that is insulin requiring a type 1, or non-insulin requiring type 2, or as milder forms of such as impaired glucose tolerance or minimally abnormal glucose tolerance. Another complexity in the evolution of the secondary diabetes is that an underlying coexisting predisposition to primary diabetes might be unmasked, not an uncommon occurrence considering the relative high prevalence of diabetes in various populations. If you look at the pathogenesis of the secondary diabetes, it may be an endocrine cause of diabetes, like that a result of an excessive hormone that are counter-regulated to insulin, like growth hormone or cortisol, or it may be by inhibiting the insulin secretion or action by the endocrinopathies. Or when that's diabetes is secondary to a pancreatic disorder, particularly when beta cell mass is greatly reduced, as in malignancy or pancreatectomy. There is a second talk on this topic alone. And when the diabetes is due to a chemical agent toxic to the beta cells, such as pentamidine or alloxine, overt diabetes will often result depending upon the extent of beta cell loss. And numerous mutations affecting the glucose sensing receptors, glucose insulin synthesis, insulin action, insulin receptor, all can predispose to secondary diabetes. So far identified these mutations involve those involving the insulin gene, insulin receptor gene, and other candidate genes such as glucokinase, insulin receptor substrate 1, and mitochondrial DNA gene. The most common cause of secondary diabetes are in this four groups mainly: the disease of pancreas that destroy the pancreatic beta cells, for example, hemochromatosis, pancreatitis, cystic fibrosis, pancreatic cancer, or it may be hormonal syndromes that interfere with insulin secretion like pheochromocytoma, or it may be hormonal syndromes that cause peripheral insulin resistance, for example, acromegaly, Cushing syndrome, pheochromocytoma, or it may be drugs like phenytoin, glucocorticoids, or estrogens. So now we will start the discussion with a case. So here is a gentleman who is 33 years old male working in Dubai. He was diagnosed to have diabetes at the age of 25 years. Initial blood sugars were around 450. And when he was admitted initially, he had urine acetone positive, ABG, arterial blood gas showed metabolic acidosis, diagnosed and treated as diabetic ketoacidosis with IV fluids and insulin infusion. Since then, he was treated as a type 1 diabetes with multiple doses of insulin, but he had a poorly controlled blood sugars, and he had multiple episodes of diabetic ketoacidosis requiring admission over the past 8 years, 5 to 6 episodes. And the last admission was in July 2021, when the final diagnosis was made. It was with the diabetic ketoacidosis again. Weight was 84 kilos. Height was 172. Funny thing, very obese guy with a diabetic ketoacidosis. Was on Glargine 36 to 32 and Novorapid 32, 30 and metformin 1 gram daily. And during this hospital visit, the doctor saw him without a mask. And then he noticed that there is a change in the facial appearance as compared to the last 2 years. And if you then took the whole history again, and there is a history of gradual onset of increase in size of hands and feet for the last 9 years, including the wedding ring become tight, changes in the facial features in the form of frontal bossing and increased malar prominence, history of abnormal sweating and joint pain. He had hypogonadal symptoms like sexual dysfunction, reduced growth of body, and facial hair. And when it was biochemically evaluated, the IGF-1 was shown to be 820 nanogram per ml, very high, and serum testosterone was very low at 1.54, and the serum prolactin level was within normal limits of 10.9. Serum cortisol level was 8.8, low normal, and his fasting C-peptide was 1.75, and his urine microalbumin was 2.7, and his TSH was 0.16, and the serum creatinine was 0.86, and the hemoglobin A1C was 10.1. All shows that uncontrolled sugars with a reasonable fasting C-peptide and then a very high elevated IGF-1 level and low serum testosterone. And the lipid profile was normal. So an MRI pituitary showed cellular lesion 15 into 15 into 13 millimeters as suggestive of pituitary macroadenoma, and modified Wilson-Hardy criteria grade 0, and nose grading was stage 1. So so the final diagnosis was pituitary macroadenoma, acromegaly, and hypogonadism. Secondary diabetes mellitus uncontrolled with a recurrent diabetic ketoacidosis. And so the follow-up, he underwent the endoscopic endonasal approach, and excretion of the pituitary microadenoma was done, was on hydrocortisone, tapered and stopped over 1 month, had transient postoperative diabetes insipidus, which was resolved. Repeat CT scan brain post-surgery did not show any abnormal enhancement. Insulin doses were reduced and stopped post-operatively. After discharge, blood sugars were managed with metformin and Bildacaptan 50/500. 2 months later, off OHS, his blood sugars were normal, and hemoglobin A1C was 5.8%. That is 2 months after the surgery. So that is the story. So we'll go to the discussion part of this. This is a story of secondary diabetes due to acromegaly. Now, if you look at the pancreatic group of diabetes which can produce secondary, one important thing is after pancreatectomy, a pancreatectomy state provides a unique model of insulin deficient secondary diabetes. The insulin withdrawal in such patients compared to the patient with type 1 diabetes leads to lower and less severe ketoacidosis, despite comparable rates of lipolysis, supporting the role of pancreatic glucagon in the induction of ketoacidosis, because pancreatic patients will not have glucagon. So even though they will be off insulin, their ketoacidosis will not be very significant. Then another group which can produce pancreatic diabetes is pancreatitis. Compromised blood flow to the islets from fibrotic scarring, exocrine pancreas appears to play a major role. Insulin and C-peptide secretory responses to various secretagogues are impaired, and these abnormalities are correlated with the magnitude of exocrine pancreatic dysfunction. And glucagon levels are markedly increased in the acute pancreatitis, both in the basal stage and following stimulation. But in chronic pancreatitis, basal glucagon may be normal or elevated. The other condition is malnutrition-related diabetes. The World Health Organization has identified 2 main subgroups: protein-deficient pancreatic diabetes or J diabetes, and fibrocalculous pancreatic diabetes. And the etiology of both forms of malnutrition-related diabetes and their relationship, if any, remains enigmatic. And one possibility is that protein deficiency might render these beta cells susceptible to damage by toxic, viral, or autoimmune factors. It is endemic in areas where cassava tapioca is a staple food, and cassava 95% starch with contains a cyanogenic glycoside. And the other important pancreatic cause of secondary diabetes is due to hemochromatosis. And hemochromatosis, one of the most commonly inherited metabolic abnormalities in white population. It is an autosomal recessive disorder. Iron deposition primarily occurs in parenchymal cells of pancreas, adrenal, anterior pituitary, myocardium, and skeletal muscle. And the classical triad of hepatomegaly, diabetes, and skin pigmentation, so-called bronze diabetes, once considered common, is now not a frequent association. Presence of symptoms usually correlate with the severity of iron accumulation. Then hepatocellular carcinoma develop in about 15 to 30% of patients, despite successful iron removal. Hemochromatosis can also result, even if it is a genetic disorder, it can also result from a number of secondary causes, including sideroblastic anemias, then chronic hemolytic anemia, multiple blood transfusions, porphyria cutanea tarda, and medical iron load condition, and also iron-rich beer. If you look at the endocrinopathies responsible for secondary diabetes, First important thing is acromegaly, which I all showed the case. Acromegaly represents a prototype of diabetes and glucose intolerance, secondary to an endocrinopathy. And glucose intolerance is prevalent in acromegaly in 60 to 70% of patients. However, overt diabetes requiring treatment occurs only in 10 to 15%. And the other condition which can produce diabetes due to endocrinopathy is Cushing syndrome, and the glucocorticoids and growth hormone are the main insulin antagonist hormones in the body. And insulin resistance induced by the chronic administration of moderate dose of glucocorticoids in normal humans is usually compensated by the augmented insulin release, resulting in minimal changes in glucose levels. The spectrum of glucose intolerance in patients with Cushing syndrome largely depends on the endogenous beta cell reserve. Glucose intolerance occurs in 75 to 80% of patients with Cushing syndrome, but only in 10 to 15% of patients develop overt diabetes. Nearly all patients, however, manifest basal and stimulated hyperinsulinemia and insulin resistance. The other is a primary hyperaldosteronism, which is a triad of hypertension, hypokalemia, and glucose intolerance. Cone syndrome occurs in 2% of patients with hypertension, and glucose intolerance previously thought to be present in 50% of these patients, considerably less common, and is usually mild form. And isolated growth hormone deficiency can also be associated with secondary diabetes. It has been long appreciated that growth hormone has a cytotropic effect on the beta cells in vitro. So the model of diabetes supports the role of growth hormone in sustaining beta cell growth and maturation during the infancy. The pheochromocytoma is another endocrinopathy which can be associated with diabetes. Here the mechanism is slightly different. Catecholamines acting via adrenogenic receptors affect insulin secretion and produce anti-insulin effects at several loci in the intermediary metabolism. Glucose intolerance occurs in 30% of patients with pheochromocytoma. It can result from multiple mechanisms, including alpha-2 adrenogenic inhibition of insulin secretion, beta adrenogenic stimulation of hepatic glycogenolysis and gluconeogenesis, and enhanced lipolysis. Overt diabetes and ketoacidosis are distinctly unusual. Hyperthyroidism, a common condition which we come across on many days, can also be associated with aberration of carbohydrate metabolism. One of the mechanisms is that the metabolic clearance of insulin is increased by 40% in the presence of hyperthyroidism. And the other mechanism are increased oxygen consumption, rapid gastric emptying, and increased lipolysis and ketogenesis. And increased incidence of glucose intolerance, which usually mild to moderate severity, has been documented in 30 to 50% of patients with hyperthyroidism. Other endocrinopathies is tumors of endocrine pancreas and gut, and the glucose intolerance of overt diabetes is frequent component of non-beta cell tumors of endocrine pancreas that secrete glucagon and somatostatin. These tumors are often malignant and quite large when diagnosed. Other clinical features of glucogonoma include a characteristic skin rash. Mild glucose intolerance has been occasionally described in patients with non-islet cell tumors like lipoma and with carcinoid tumors of pancreas or gut. Polyendocrine autoimmune syndrome, insulin-requiring diabetes has been observed in 50% of patients with the polyendocrine autoimmune syndrome type 2, and characteristically multiple generations are affected. In type 1 syndrome, the affected relatives are siblings in a single generation, and there is no increase in HLA, DR3, and DR4. These patients may have insidious onset of diabetes years after the onset of initial endocrinopathy, such as Addison disease or thyroid disease. And POEM syndrome is another rare endocrine condition which can be associated with the glucose intolerance. Sometimes insulin requiring has been reported. The full form of POEM syndrome is polyneuropathy, organomegaly, endocrinopathy, monoclonal gammopathy, and skin changes. It is a rare form of plasma cell disorder. Now coming to the drugs, chemicals, and toxins associated with secondary diabetes. The most important is diuretics and beta-adrenergic antagonists. And the diabetogenic effects of diuretics, particularly the thiazides and chlorothalidone and beta-adrenergic agonists, have been well recognized in clinical practice. The other drug-induced secondary hypertension possibility is diphenylhydrandoins. They have directly inhibitory effect on beta cell secretion. This appears to be the dose related, and there are occasional cases of hyperglycemic non-ketotic coma precipitated by dilantin. And then the glucocorticoids, oral contraceptives, and progestins are a group of hormones, drugs, which can also produce secondary diabetes. Glucocorticoid-induced glucose intolerance is characterized by insulin resistance and hyperinsulinemia. The effect of sex steroids on carbohydrate metabolism are somewhat controversial. The effect of oral contraceptives on carbohydrate metabolism in young women are much more dependent on the formulations, particularly on the dose and relative potency of the progestin component of the pills. The incidence of overt diabetes is distinctly rare in individuals without a family history of diabetes. Pentamidine and Vacor, and these are all, pentamidine is anti-protozoal and Vacor is a nitrourea derivative pesticide. And these are all chemically resemble to streptozotocin and alloxin, and the sequence of events leading to diabetes with these agents is similar to that seen with streptozotocin due to beta cell lysis lasting for hours. And nicotinic acid causes glucose intolerance by inducing peripheral insulin insensitivity. However, significant hyperglycemia or deterioration of glucose intolerance may result in patients with limited beta cell reserve. Cyclosporin, an increased incidence of diabetes has been reported in renal transplant patients treated with cyclosporin, particularly in the Black population, in whom a 20% incidence of post-transplant diabetes was reported. Direct inhibitory effect of cyclosporin on beta cells are the likely explanation, although effect on muscle glucose transport is also possible. Opiates, hyperglycemic effect of morphine and other opiates has been recognized. Beta endorphins and enkephalins are produced in the human islets, which are diabetogenic. Now coming to the other specific types, that is genetic and syndrome related one. See, genetic disorders of beta cell function, the whole group of MODY is based on this. And for example, MODY3 is based on HNF alpha gene mutation, and the MODY2 is based on glucokinase gene mutation. MODY1 is based on HNF4 alpha mutation, others are there. Then also genetic defects of insulin action like type A insulin resistance, Rapson-Mendelssohn syndrome, lipoatrophic diabetes and others are also related to genetic mutations. And genetic syndromes are sometimes associated with diabetes. For example, Down syndrome, Klinefelter syndrome, Turner syndrome, Wolfram syndrome, Lawrence-Moon-Beadle syndrome, Prader-Willi syndrome and others are associated with diabetes. Immune-mediated diabetes is the Stiffman syndrome and anti-insulin receptor antibodies and others. Now the question is, secondary diabetes, when to suspect? That is the main topic. And so the most important thing is the detailed history and physical examination is the cornerstone in suspecting secondary diabetes and making a diagnosis. So when you take a history of abdominal symptoms, a history of recurrent abdominal pain, admissions, surgery in the past, in a type 2 looking patients, must give a clue that there may be a possibility of a pancreatic diabetes. So if there is any history of abdominal symptoms in the past, and also don't forget to think about pancreatic cause of that patient's diabetes, and do a minimum investigations like doing an abdominal ultrasound and a few blood tests will clear the doubt that whether this patient belongs to that group or not. Then a history of diabetes in 2 generations in a young or non-obese patient. For example, when a patient with 18 years, 19 years, 20 years coming, the question is whether it is a type 1 diabetes or a type 2 diabetes aware. But remember that if that patient is not obese, it can't be type 2 diabetes aware. Then you look at the history of 2 generations of family history of diabetes, then it gives a clue that it may be belong to the MODY group, and you can do the genetic studies. And the good physical examination of head to foot will remind you about the possibility of endocrinopathies. That you must remind you about acromegaly, about gigantism, about Cushing syndrome, all can produce secondary diabetes. And only if you do a physical examination, you will suspect these endocrinopathies in a diabetic patient. So finally, history and physical examinations. together will give you a clue regarding the genetic syndrome, family history of mental retardation, short stature. All these will give you a clue to this absence of menstruation, to Turner syndrome, Klinefelter syndrome, all these genetic syndrome. That will give you only the physical examination and a good history take will give a clue, and that will direct you to look for a secondary causes of diabetes associated with these genetic syndromes. What about the investigations? There is nothing different. It is investigation depends upon what is if it is a pancreatic disease responsible for it, you go on that direction. It is an endocrine cause, refer to the endocrine to exclude the endocrine causes. If it is a genetic one, you'll have to do the gene studies and mutation studies to confirm or exclude this. So diabetes masking as an endocrine or pancreatic defect, the prevalence of secondary diabetes is increasing because the lengthening of life expectancy of people affected by genetic, acquired, dysmetabolic, and neoplastic pancreatic disorders. But these may remain unrecognized after a diagnosis of diabetes has been made. So even if a diagnosis of diabetes, don't forget about the associated possibilities of a pancreatic disease the patient having. Conversely, a correct diagnosis, secondary diagnosis is fundamental to ensure satisfactory glycemic control while avoiding hypoglycemic episodes as much as possible. Taken as such, 90 to 95% of diabetic patients will be diagnosed as having type 2 diabetic patient, but about 3 to 8% will have other specific type of diabetes. It may be secondary to endocrine, genetic, or environmental, or at other cause of defective glucose handling. So in conclusion, I must say that the category of other forms of diabetes, even though rare, is becoming more important because you should not miss it because there are facilities to make a diagnosis at this present. It is a challenge for the diagnostic and therapeutic skills of the diabetologists, endocrinologists, and the internists. The case I have presented, the first part, the acromegaly with diabetes, clearly shows how a patient dubbed as a type 1 diabetes with multiple ketoacidosis, going from hospital to hospital, taking multiple doses of insulin, is now walking around as a non-diabetic individual because a correct diagnosis, the physician happened to look at his face and it clicked in the physician's mind about the possibility that this looks little acromegaloid. So then going back and taking the history, it was able to make suspect the diagnosis. And once the diagnosis is suspected, because there is a protocol is there to follow to make a diagnosis of Cushing syndrome or diabetes, well-written protocols are there. If you do on that lines, you will be able to confirm it. And if you are able to confirm it, majority of endocrine problems, you can treat it. And that is why that patient is walking with a hemoglobin A1C of 5.8 and as a normal individual without any diabetic medications. And so they should be aware not only of the specific therapeutic requirements of this patient, but even more so of the necessity of suspecting that what might look like a mild diabetes may be associated with conditions for which an early diagnosis can have life-saving implications. So my take-home message is, think about secondary diabetes. When you are a diabetic patient, does not look like a classical type 1 or type 2 or looking little funny. Think about their secondary cause and you will be successful. Thank you very much.